So we have a great speaker this morning, Dr. Susan Rogers. She's president-elect of PNHP. She's recently retired, but she was a volunteer attending hospitalist and internist at the John H. Schroger Jr. Hospital of Cook County, and previously co-director of medical student programs for the Department of Medicine. She's also an assistant professor of medicine at Rush University and assistant professor of medicine at Rosalind Franklin University. And she's received numerous teaching awards. She received her medical degree from the University of Illinois College of Medicine and completed her residency at Cook County Hospital, where she served as chief resident. And she's a past co-president of Healthcare for All Illinois and has served on the boards of the Near North Health Service Corps and FQHC in Chicago. And she's a member of the American College of Physicians, the Society of General Internal Medicine, and the National Medical Association. So give it up for Dr. Susan Rogers.
Thank you very much for that introduction, and good morning all. It is just really great to see you all here. As I said, I'm Susan Rogers, and I've spent almost my entire career at Cook County Hospital or at a community health center. So I have been taking care of patients all my life who had difficulty accessing care. Social determinants of health were a big impact on their medical outcomes. So I'm very passionate about getting health care for everyone, but I think it is important. I don't know how many of you saw the video that I placed. Did you all see that? Take a look at it. It's good, really. But it's the part of the kitchen table topics that we are doing for PNHP. And one of the things I said in that video is that access to care, or Medicare for all, is just one step in eliminating health disparities in this country. And that's why I say it's always been, equitable health care has been about civil rights. And I want to show you why this, a little history. I'm glad I didn't go through statistics of disparities because of the presentation that you just did. But I want to go through the history of why are there disparities in the first place? Why are so many black people poor? And I hear a lot of times from people, well, I work hard, they should work hard. And if it was that simple, black people have worked hard all their lives. So if it was that simple, then what's the problem? So let me see if I can get this thing right. Okay. All right. One of the things about the economics of medical care in this country is that it's made treating poor patients something nobody wants to do. We have a two-tiered system here. Even when Medicaid was developed, which was to address the health needs and other needs of people who were poor, it was totally underfunded. And there's no way that somebody can keep their office doors open if their practice is only Medicaid. Medicare is close to that too. It's grossly underfunded. So poor patients are people that no one wanted to treat because there was no way that you could even pay yourself a salary. So what are health disparities? We look at health disparities and they refer to differences in health and health care between population groups, socioeconomic status, disability, and all of that. But the crucial test of whether these differences are unfair really depends upon whether you can apply that difference to the whole country. And that's where the term health inequities comes in. And health inequities, I like that term better because it has a moral implication, the whole thing about being unequal. So that health inequities, they are unnecessary, they are avoidable, they are unfair, and they are unjust. And when you look at the states that chose not to expand Medicaid, that was unfair and unjust. And I'll show you a statistic that will confirm that. So that as long as we continue that, we will always have health inequities. And I mentioned this before, so I'll just skip on with that. Achieving healthcare equity, there are several things that we're going to need to do to make sure that healthcare is all equal. And what we need to do is have equal access for equal needs. So that means if two people need the same procedure, the same imaging study, the same care, that they should all have equal access for that equal need, which means that access has to be geographically available, that there have to be providers to provide that service. It has to be distributed throughout the country so that everyone has equal access for equal needs. Now, those needs may vary geographically, but that's okay. You still have to have equal access for equal needs. You also have equal utilization for equal needs. So that means that if two people go to the hospital for the same need, they both need to be treated for that need and not someone get pushed to the front of the line because of social preferences, because they think they are more worthy, or for whatever reason, socioeconomic status. You can't push people to the head of the line if the needs are the same. And I don't know if you had heard, I hadn't heard what happened with it, and I can't remember if it was a Mayo Clinic or Cleveland Clinic, but their CEO made the comment that they were going to drop people who had Medicaid to the bottom of the list of people who needed their services. He said this in public. I can't make this stuff up. So this is what equal utilization for equal needs should prevent, the ability to move people to the top of the line. And we also need equal care, quality of care for all. And I think this is very important because if we look at what has happened with public education after Brown versus the Board of Education, and we said that separate but equal was not really equal, we have to make sure that the quality of care in poor neighborhoods is the same as in wealthier neighborhoods. So just like black schools, after during segregation, they had books that were old. They were discarded books from white schools. We can't have that done with facilities in poor neighborhoods. They can't get the x-ray machine that is no longer state of the art because that's all that they can afford. So Medicare for all would help account for quality of care for everybody, but that will take a lot of work. Just keep in mind, your journey is not over just by when we achieve Medicare for all. So let's look back at the history of why we have inequities. And this is a very, I think, kind of an interesting history lesson. Back before, in the late 1800s, and actually it was during slavery, and there was a doctor who did a study on cranium sizes, and he did this by getting these skulls and filling them up with seeds, and he had white skulls and black skulls, and so he figured out what the volume of each skull was. And interestingly, there was a physician in Europe, I think Germany, that was doing the same study, and they came to totally different conclusions. Talk about research bias, it's been there for years. But what he found was that black people had smaller brains than white people. So of course they were inferior. Now, two things with this conclusion. One, just because something is smaller does not mean it is inferior, but it was just a justification to provide for what they already felt or what they already thought was fact. They had proven it, that they were inferior. Over time, this has been proved untrue. His study calculations, the way he did this study, really did not prove what he thought. Then there was spirometry. Spirometry developed in the 1800s, and this was done especially because there was so much TB in that area that it was used as a tool to kind of help prognosis and try to, figure out lung disease and what was really wrong. And so they came up with, they did studies on, of course, slaves and white people, and they found that the vital capacity was less for black people. And of course, this meant they were inferior. And this was how they justified slavery. And I found this to be so, I don't know, I can't make this up. I keep saying that. But What he said was that slaves need to work hard labor because then their lungs will function more, and then they will get more blood to their brain, and that is good for them. However, if they are left to not working hard labor, their brains won't get enough blood, so then they can't function as free people. So this was their justification of labor, that under normal circumstances, our brain didn't get enough blood, so we needed to work hard labor to do that. Then there's pain control, and you all have heard about recent studies that have shown that there's bias against patients, minority patients getting treated with analgesics for the same conditions, like long bone fractures. There's no question that those are painful, but the impression is that Black people can withstand more pain, Hispanics can withstand more pain, so that those patients weren't really treated for pain control accurately. And that's based on a false assumption that they don't feel pain the same way. The only silver lining to that is probably the reason why you don't see as many Black people with opioid addictions, other than heroin maybe, but you don't see that opioid addiction because Black people were never given prescriptions for opioids as much. Then, are any of you familiar with the drug Badil or Bidil? There's different, yeah. When I was a medical student, they came out, I'm really dating myself, and I'll be honest, I graduated medical school in 1979. Penicillin killed everything, and DIG and Lasix was all we needed for heart failure. So medical school was actually easy. But there were studies that came out that started using nitrates and hydralazine to treat heart failure. And so that was, they were used in 2 different pills, and so we dilated we decreased the preload and the afterload, and that helped a lot of patients with end-stage heart failure. So what Badil was, when they did these studies, later they found out that there was a difference in Black patients who were in this study, although there weren't that many, didn't seem to do as well. So one of the researchers here saw this as an opportunity to make money. And so what he did was he did a study with only Black patients, and he changed the doses a little bit so that he could get a patent, because then it's a different drug if the dose is a little bit different. And it showed that Black people improved with this drug. And so it became marketed as a drug for Black patients with heart failure. Now, a couple of things from this. Those of you who are in your clinical years, you use guidelines, right? All right, there's a lot of A guidelines. And so we use guidelines to determine what to do with certain conditions, how to treat, how to work up, whatever. Most of the guidelines are based on studies that have mostly white patients in those studies. I mean, it's just the history of what's happened. And we extrapolate those studies to the Black patients that we treat. Correct? So why isn't a study that is only with Black patients extrapolated to white patients? No one has the answer? You know the answer. But so the FDA sort of approved this drug by saying, well, yeah, Black people are genetically different, and so their heart failure has to be treated differently from white people. So we haven't moved that far from the studies done in slavery about the genetics, even though the Genome Project has said that we are all 99.9% the same, and whatever differences. And race, as we all know, is a social structure. Race was developed, white and Black, really to determine who could own a slave and who could be a slave. And that's why that one drop rule was established. So genetically, am I more Black than I am white? I know. All of you have mixed heritage. There's mixed gene pools in who you are. So this whole idea of race as a genetic thing is just totally in error, but it still continues even to this day. So this is a copy of a book that, a study that W.B. Du Bois did in 1899. And this was actually the first academic challenge that was ever done to explain the differences in the racial gaps of healthcare. And he did this study looking at people with TB and to try to determine why is it that black people died more and had more complications from tuberculosis than white patients. And he really found that it was really because of unequal social and political conditions that caused this difference. And he based this too on the fact that Irish people, who were not well liked either in this country. They weren't considered totally white at the time. But they had poor outcomes too because they were delegated to live in areas that had low sanitation and not a lot of social amenities there. So what this study did, it really provided a lot of the basics that public health uses today. And if you look at how he did this study, it's amazing. I don't know how he did it with pencil and paper. There was no other way to do all this calculations. But he brought up the whole idea that social situations influenced health. So I put this timeline together and I'm going to go through some of the points on here, but I wanted to kind of show some of the things that have happened over the years that have created the political and the social climate that we have today. And I will refer to some of these, but starting out in 1860, almost all blacks were slaves at that point. And we'll end now at the ACA, which is beginning to be chipped away by the current administration, and the positives that they provided are not even all there anymore. But segregated housing has actually been one of the cornerstones of inequities in this country. And this is a sign that was put up by a white community when they wanted to build some public housing in Detroit back in 1942. So this is in the north, this is Detroit. So segregation is not just a southern thing, it was in the north too. Now in 1934, the Federal Housing Administration was established, and what this was one of the first times that you could get government-secured mortgage. When you get a mortgage today, you go to the bank, and then you decide on the loan, whatever, and it's backed by the government, okay? Now, what happened was that of all the home ownership loans that were approved at this time, whites received 98% of these mortgages. Was that because only 2% of black people could afford a house? No. So and this was right after the Great Depression, and we were trying to build up the economy again. So there was a thing called redlining, and I don't know if you all are familiar with this. Redlining was what they did, and they're still done at some aspect today, in that you determine where the house is located and if this is a good place to buy a house and if this house is worth the money that you want to get the mortgage for. So if you want a mortgage for $200,000 and the house is only worth $100,000, they will not give you that mortgage because you owe more than what the house is worth. You have no benefit to pay it back. So what they did was they redlined and they designated some communities that they would not give mortgages to because they were bad investments. They would never amass wealth. They would not grow in value. And these were neighborhoods that had at least one black person living there. That was redlining. They also developed, and these were developed more by communities and local governments, restrictive covenants. And this was where you couldn't sell your house to anybody black. So even if you lived in a integrated community, or especially if you lived in an all-white community, that community would never become integrated because you could never sell to anybody black. And one of the ways I found this quite clever, how some communities got around this, because later it became that this was illegal, but the way they got around that was because there were laws that said races could not intermarry. What they said was you couldn't buy a house in this neighborhood unless you could marry somebody on the whole block, marry the majority of the people on the block. So if you were black, you couldn't buy a house the block was all white because you couldn't marry anybody who lived on that block legally. So this was how they skirted that, not by saying because you were black, but they kind of didn't mention race, but it was clear what they meant. So blacks were stuck with having what we call contract mortgages, and what those were is they were not by banks, they were by predators and really unscrupulous people, and what they did is you bought the house for more than what it was probably worth, and it was almost like a combination of renting and ownership, because you were an owner in the sense that you had to fix everything that broke in the house, but you were a renter in the sense that you didn't incur any equity. You got no equity in the home until it was completely paid off. And then, on top of that, what they did is they overassessed these houses. So black people in these homes paid higher taxes. So people ended up having to work 2 and 3 jobs to be able to maintain their house, and many of them lost their homes. And because they lost their homes, because they may have missed a payment, they had no equity in the home. So they just lost everything that they put in there. And this destroyed a lot of neighborhoods, of course. And this even continued before the real estate crash in 2008. This is exactly what happened. Home loans were by banks, they preyed on minorities. And there were a lot of people who were eligible for regular mortgages, but they were directed and driven towards subprime mortgages, which were not in their benefit, which when the interest rate went up, they were not able to afford those homes anymore. So they lost their homes. So this was, again, predatory mortgaging. It's still continuing. And it amazes me how, I still hear, after Obama was elected, we are now post-racial. But clearly, these policies and all show clearly that we're not. And this is just a map that shows redlining. And this is exactly what it was. In those red areas, you could not buy a home. And so the separateness, the segregation of black and white families has contributed significantly to the entrenched inequalities, and that this enormous wealth gap that came, this was one of the big causes. Buying a home was the main way that people got wealth, and their unequal access to good public schools and unequal access to health care. And you can see how the gap between black and white wealth is just incredible. Just incredible. And what wealth does, and wealth is actually more important than just income, because you can have 2 people with the same incomes, but if one has no savings, they have no safety net. When something comes up, they're stuck. Whereas even with the same income, you have a safety net. If you need new tires on your car, it doesn't have to be anything necessarily big, but if you have no safety net, and because of no wealth, you're at risk of just damage. And so what has happened is that the segregation and all these racial disparities have resulted in what we call concentrated poverty. And what I want you to get from this is that black poverty and white poverty are not the same. They are not the same. What this shows is that there are more poor blacks living in concentrated poverty. And by concentrated poverty, that's where more than 40% of that population is below the federal poverty level. Do you all know what the federal poverty level is, how that came about? That's important to know because we use those terms a lot. But the federal poverty level was developed back in around Social Security in the mid-60s. And what it was developed by the Social Security Administration as what's the minimum amount of money you need to be able to live for a month. So you all figured out what's the minimum amount you can live on for a month. And that means what would pay your rent, what would pay your utilities, transportation, food, and all of that. And that minimum amount for a month was never intended for that's what you're to live on indefinitely. But that's what has happened. is that this federal poverty level has determined what people live on indefinitely. And it is clearly not something that is sustainable. And that is concentrated poverty. People who actually cannot really make ends meet and they get stuck there. And so if you look at New York, 25% of poor black people live in, the percentage of poor blacks live in areas of concentrated poverty. In only whites, only 15% of them. And then you look at some place like St. Louis. You've got almost, where is it on this list? You've got about 30% of poor blacks living in concentrated poverty compared to less than 2% of whites. And if you are surrounded by other people who have nothing, is much different than when you're surrounded by other people who do have things. And those communities tend to have better schools, better social services, better transportation, all these other things that make a community a community. And so these policies have created this situation. This didn't happen because they didn't work hard. This happened because of federal and local policies that have happened. And this is just another way to look at it. And this is more of a national picture, that you've got 25% of black people now who are living, poor people who are living in concentrated poverty versus 5% of whites. So the opportunities available to poor whites are significantly more than what is available to poor blacks. So what they've done now that we can't say, well, you can't buy this house because you're black, what communities have done now is they've made zones so that they keep affordable housing out of their communities. So that there's no way for people in concentrated poverty to leave. And those that do leave, what happens? They end up going to nearby suburbs who then become poverty-stricken. And then the area of concentrated poverty becomes bigger because the people who can't get out continue to stay. And as the people who can leave, the percentage in concentrated poverty increases. So it's sort of a self-fulfilling prophecy. I mean, you know that this is gonna happen. And, you know, one of the responses to these neighborhoods has been mass incarceration, stop and frisk, all these other policies, that actually this is what they created. This is exactly what was created. So let's go on to FDR, and everybody touts FDR. This was wonderful, the New Deal, it saved us, you know, after the Depression and all. Well, let's talk about Social Security. When Social Security was developed, what it was is that it gave people who were over 65 a safety net, and it provided some income for them. Well, did everybody get Social Security? No. Who didn't get it? Have you been listening? Farm workers and domestics, most of whom were black, did not get Social Security. So they didn't say black people can't get this. If you look at the Deep South, where most slaves lived prior to the end of slavery, before the migrations up here, most of them were farmers. And those that stayed, and I'll get into this later about how the land was stolen from them, but they were not, these policies, the advantages of these policies were not given to them. Let's look at aid to dependent children and families, and this was developed in the 30s, and it wasn't called welfare then, but actually it was a program to help white women who had children and were not working. But this was also a time that white women really weren't expected to work, because black women who had children and were working couldn't get this. And then when it was spread to include black women who were not working, it then became called an entitlement. We can't have that. We can't just give them money for not working. So these are the policies. This is the setting, the milieu in which these policies were developed. And then when we talk about farm subsidies, this is just incredible what has happened in the farm. After slavery and after, after slavery ended and before Reconstruction ended, a lot of black farmers who lived in the South, they still live there, some were able to get their own land. And actually the number of landowners in the Deep South were more than white landowners. And even the population, because of slavery, there were more black people than white people in the Deep South especially. So they came up with these, so a lot of black people own land. And so over the years, banks, and there were unscrupulous predators and any sort of activity involvement with the NAACP or voting rights groups or that by farmers. They had their loans taken away or whatever, and little by little, the black ownership of farms decreased. But it was essentially stolen from them because if they were involved in the NAACP, they couldn't get a loan. And the way farmers function is they get loans based on next year's harvest. So if next year's harvest is no good and you didn't get a loan, you can't function. So this was done to help destroy black farmers because even then, the white people in those states knew that they couldn't be the minority of the voting group. And that was also why all these poll taxes, literacy tests, and all of that, because black people had gotten, well, it wasn't black people because only men could vote then, but black men were able to vote after the Civil War. The 15th Amendment gave them the right to vote, or was it the 14th? I forget, but they were able to vote, but then they applied all these other restrictions only to them, the poll tax, the literacy test, or whatever. And so these subsidies ended up taking a lot of the land away. And this included, actually, the peak of this was in the 50s. So this is not old ancient history. This is part of our generation, part of my generation, that these farms were taken away. And then in the height of the farm crisis, and this was back in the early 80s, and we now had the U.S. Department of Agriculture, and they came up with these loans that were backed by the federal government, and they had $1.3 billion to give away. They had more than that, actually. But what they did is they gave over $1.5 billion to white farmers, to 16,000 farmers. Let me get this straight. Only 209 of those farmers were black. So they took the land. And it was, deeds where you needed legal help. And, even when I need legal help, I don't know what they're saying to me. Just like, when you talk to patients, and a lot of times they don't know what you're saying. But, did I read all 25 pages of my mortgage? No. With that font of 2, there's no way you can get through. So they were legally, because of the laws at the time, those lands were taken from them. And so, and a lot of that was so that they could not vote. You decreased the voting numbers of black people. Now let's talk about the GI Bill. And this happened after the World War II, and all these GIs came home from the bill, and so from the war, and they created the GI Bill. And this was to help the GIs get restarted. And so they had home loans to GIs, but less than 100 out of the 67,000 home loans went to black GIs. A lot of this was because of redlining that was at the time. Only 2 of 3,200 VA loans went to black GIs. The training facilities, they had programs to get new training, to get a new skill and stuff. They were segregated and unavailable to blacks. Colleges in the South, if you wanted to get a GI Bill for college, you couldn't go. So if you look at this, the Tuskegee Airmen, they weren't allowed to become commercial airline pilots. Now the commercial airline industry was small at this point, but they were still excluded from any sort of opportunities to get into that market. So all these bills that were supposed to quote, made the country great, are not taking into any account of how these policies affected blacks in this country. And even my father still had to sit on the back of the bus when he went back home in Georgia. So, along with all these policies and things that clearly disproportionately affected Black people. There's also the fear of healthcare by minorities that affects health, that is one of the causes of health inequities. And this book, Medical Apartheid, written by Harriet Washington, I couldn't get it to clear up when I made the slide bigger. But this came out maybe about 10 years ago, maybe longer than that. I couldn't finish it. I found it too disturbing. It was awful. Now, things like the Tuskegee Syphilis study, I think we're all aware of. That was probably one of the more benign things they did. All right. I mean, I think that the Nazis learned from some of these studies of what to do. It's just atrocious. But these are what they did. They still were not considered people in the same way, and they had free license to do whatever they want. So this fear of health care by minorities, I think, is justified. This is what has happened. And this has been recent. I mean, the people, it may be 1 or 2 generations ago, so that these stories are still being passed down. This still affects current families directly. Back in when Medicare and Medicaid were established, Martin Luther King was crucial in that. And so was the NMA, which was organized because the AMA did not allow Black physicians. It wasn't until then, 1964, that Blacks were allowed into the NMA. And so they were crucial, and that is why I say that health care is part of civil rights. It is a right, and we all believe that health care is a right, and so we have to look at it as a civil right. But this was it was part of it was important in the passing of this bill that the federal funding be tied to desegregation of hospitals when they accepted this money. Now, does anybody know what this is? Anybody here from Atlanta? This is Grady. Now, Grady was really started back in the 1800s, and this is the 3rd Grady Hospital, I think, that was built in 1958. If you notice those 2 towers, one's the tower for Black people, and one is the tower for white people. So back in 1958, this was a segregated hospital with no Black doctors. So this is not old. This is part of the recent past. This is in my lifetime. Maybe some of your parents' lifetime, but most of your parents I know are younger than me, but that's okay. But it's funny, when I started working with medical students, my girls were young, and now you all are like younger than them now, and it's just, anyway. So this is Grady Hospital, and this was flagrant segregation. It was clear what door you went into. You didn't need a sign that said whites only. It was clear in the policies of what was appropriate. Now, there's also a thing that we call weathering, and this has been probably up in a lot of the sociology literature over the last 10 years. And what it discusses is just the stress of being Black in this country. And that because even if we look at maternal mortality, which is skyrocketing, was it Venus or Serena that had the baby? Clearly, with her socioeconomic status, care was not an issue for her. Her social determinants of health were not an issue in her getting health care. Why did she have a dire complication that almost killed her? So this weathering, and what people propose is that under stress, you produce more cortisol, more cytokines. It gets very complicated, but it ends up affecting your health. And that's why, even if you look at life expectancy statuses, those statistics that even adjusted for socioeconomic status, Black people don't live as long as white people. So it's a real thing. There's no test for it, and you've heard the terms driving while Black, shopping while Black, walking down the street while Black. Those are real issues, and they affect people. and how they affect them, even if we can't quantitate it with, cortisol levels, they do have an impact on the way people function and the way they deal with stress and what happens in their lives. There's also a lack of minority physicians. I don't think that the percentage has increased since I finished school in '79. And despite, there may be a few more absolute numbers because class sizes have gotten bigger, but the percentage of black physicians has not really moved a lot, unfortunately. And I think the class is now, it's a little bit, you have to be careful about the data because there are more Hispanics and Asians who are in medical school, and many schools consider those as minorities when they look at their calculations. I'm on the admissions committee at Rush, and we have a designation underrepresented minorities, and those are where blacks are. Asians are not underrepresented, so they are not considered minorities there. But there is this lack, and the issues are myriad. There's a lot of reasons why there are black physicians. But I want to show this picture. Do any of you know who these people are? This is my graduation class from medical school. Not my class, but the minority students, the black and the Hispanic students in my class. I'm the cute girl at the end of the bottom, the front row. But the thing, look at all the black men in that picture. There were more black men than there were black women students. Now, when I was in school, there were also more men than there were women students. Now it's almost 50-50. But still, the number of black men has not maintained that difference. There's still fewer. A lot of this may be from mass incarceration. The pool is just smaller because so many have been put in jail. Illegal. I won't go there, but that's a whole nother issue. But that's part of the issue. But this is what my class looked like 40 years ago. So, and then if we look at the ACA, black adults in the expansion states were almost as likely as white adults to have a usual source of care. So the ACA did help. Obviously, care does make a difference in how people function. And having a usual source of care, whether it be a hospital or a clinic or a doctor's office, a community health center, whatever, is really a sign of a neighborhood's health access. And it's a positive, it's a good thing. But the expanded eligibility wasn't available to nearly half of black adults and almost a third of Hispanics, causing, it was an inordinately negative impact on these groups. And almost 46% of black working adults live in the 15 states that did not expand Medicaid. Now, here's a picture. This is a share of the population that is black by state and the Medicaid expansion states. What a coincidence, those states in the South, huh? So, Medicaid expansion works, it helps, but it doesn't solve the problem because it's left to the states. And the states will find a way, local communities will find a way. And I say that because our protest, our work for Medicare for All doesn't end with the passage of the bill by Sanders when he becomes president. Okay? It doesn't end there. It doesn't end with achieving that, because you can see that there are ways to get around that. This country has found ways. This is not a post-racial society. There will be a way to continue. Look at what happened with the board, with Brown versus the Board of Education. Do you know the most segregated schools now are in New York State, in the north? So it's not just the South. It is. I live in Chicago. I can tell you it is the most segregated city ever. If you look at the city statistics, it's 30, 30, 30. 30 black, 30 white, 30 Hispanics. Say, oh, that's a great city. But it's all in different neighborhoods. All the neighborhoods are segregated. And by segregated, there's different definitions. Black people have a different definition for segregation than white people, but in essence, they are segregated communities for the most part. So you can see how Medicaid expansion did help, but it wasn't the solution because it wasn't national. So in order to address this, we can't go state by state. We have to have a national Medicare for all. And I put this slide up here because this is an article I think you all should take a look at. This came out a couple years ago, and this is the poster child of health inequities. Cleveland Clinic it's a phenomenal institute. I've never physically been there, but it's sort of like a city in itself. They even made a new road to get to the Cleveland Clinic so the people who worked there from the suburbs didn't have to drive through that poor community that surrounded it. And that was built by the government. So the government sanctions this. So you see, it doesn't have to be overt. There's reasons why things are done. And so you have to keep your eyes open. You have to be, and when people, I hear you're playing the race card, that's often not true. There really is a race card there to be played because of the policies that have come up in this country. So Medicare for all, we clearly need, but that's not going to solve all of our problems. But you can't do anything in life. Well, that's not right. But having a healthy population increases the availability of people to do things. The whole area is healthier. But if you have a group that is living in concentrated poverty, they are living on survival mode. They're just trying to get to the next day. And so you can't have the majority of black people living like that. You'll never have an equal society. So we have to make sure that this inequality, when we address inequality in healthcare access, that we also have to hook it to schools. We have to look at to grocery store locations. We have to look at other things, pharmacies. If you have a hospital without a pharmacy in the neighborhood, that doesn't really work. So it has to be all of these things that work together, and we have to be part of that big picture. I'm not saying don't focus on Medicare for all, because that is what I'm saying. You need to focus on Medicare for all. There are other organizations that are focusing on housing, that are focusing on other determinants of health, but we have to kind of try to work together to kind of address some of these disparities so that we all can be healthy. And I think getting that point across that we all need to be healthy is one that a lot of this country has been resistant against. And I always like to ask, well, when's the last time you went to a restaurant? And people say, oh, last week or last night. When's the last time you all went to a restaurant? Regardless, do you know who cooked your food? Did they have 3 negative cultures after their salmonella diagnosis? I mean, you don't know how healthy they are cooking your food. So we should want them to be healthy. I know that when my children were young, I had a woman who came in, that was before nannies were real popular, but she came into my home and took care of my children. She was an older black, I called her older black, she was younger than what I am now, but she was a black woman, wonderful woman who loved my kids to death. And I paid for her health care out of pocket because I didn't want her to have a stroke at home alone with my baby because she couldn't get her hypertension medicine. It was worth whatever I had to pay. So it is to our benefit that everybody is healthy. And you saw this slide first, but I thought I would end with this. Actually, there's one more slide that I want to show, but single payer for all does mean fewer racial health disparities. And one of the things we have to remember is there cannot be a group that is disadvantaged without there being a group that is advantaged. So we're not taking away what's normally or rightfully theirs. They took away from someone else to make them disadvantaged. So you're just trying to equal the playing field. And the issue that a lot of the advantage group can't grasp is that this has been the status quo for so long. that it's difficult for a lot of people to wrap their arms around that. But I hope that all of you sitting in this room realize how advantaged you were, that your parents were able to benefit from housing loans, most of you, from the GI Bill, if you have farmers in you all benefited from that. My ancestors did not, but I'm still here. So don't say I didn't work hard. So, okay, that's my talk, and I hope you enjoyed it, and I hope it improved your perspective on why there's healthcare disparities and why Medicare for All will help, even if it doesn't solve the whole thing. I think we have a couple of minutes if there's any questions. Medical students always have questions. What is this? That's okay. Go. Yes. That's another one. Yeah, they're inappropriate because even if when I talked about the vital capacity, that, there's a genetic difference in that. Even if you look at PFTs, there is a different calculation for black patients and white patients. Same with GFR. It's a different calculation. So I like the idea that I'm considered muscular, but, it's not, it's based on bias. And, I don't know why it has persisted 100 years. And, I don't know why. And I think there's part of the reason why is because it would probably be difficult to get funding to do a study to prove that that doesn't apply anymore. And so rather than do that, people are just going on with the status quo. But yeah, it's a problem. It's obvious bias that because it's so obvious and it's been there for so long, it's not even seen for what it is anymore. Yeah.
I was wondering, so we know there's a lot of racial disparities in different practices in use of medicine today. We see that opioids being prescribed in different ways, and also recently the private insurance companies using different algorithms for different racial.
Mm-hmm.
I'm wondering, what are some other practices that are used today in the medical community that might not get as much media attention that we should be aware of or sensitized to?
Well, if you look at things like substance abuse, that has decimated the black community for years. And, people need to realize that the reasons that a lot of people get addicted to drugs are for social reasons in their life. They're unhappy. There's frustrated. There's things that have happened that's the only way that they can function. And rather than address those issues or address the substance use, it just gets ignored. But now that white people have the problem, it's a country epidemic. That's bias. And even the whole idea of treating substance abuse, there's not much funding for it. It's expensive if you're going to pay for it yourself. And if you had those monies, you probably wouldn't necessarily be addicted to heroin or something else. But, the whole crack cocaine thing, why was that disproportionately, criminalized more than regular cocaine because it affected the black community? So these things, they filter all the way down. And even with health care. And, to get to Medicare for all, if you look at, I'm on the faculty at Rush, and Rush is a large institution and they pride itself on, being involved in the community and all. But when you have a profit-driven system, they function on making more money. And so they, right across the street from it, they knocked down all this housing that had been there. And it was nice housing. It wasn't that old. There was nothing wrong. But they knocked down that housing, and that was where actually a lot of students lived. And they're building a cancer treatment center there. Now, 5 blocks away, you've got Health Inequities. that this cancer treatment center isn't going to address at all. For one thing, you've got Rush there treating cancer. You've got Cook County Hospital where I was. We see more cancer patients than anybody in the city. Because when you think about it, you get a diagnosis of cancer, you're too sick to go to work, you lose your insurance. Where are you going to go? You come to county. We've got the University of Illinois Hospital. We've got the Jesse Brown VA Hospital. There's all these other places to treat cancer. So why are they building a cancer treatment? Why aren't they building a mental health facility where the needs of the community are great? A substance abuse center. Why not a pediatric center for preventive medicine and school physicals and all that? There's no money to be made in those other things. So Medicare for All is a way to prioritize these resources. It's the only way that we can prioritize these resources being placed in communities where there is need. Yeah.
I was wondering if you could talk about like what you imagine like certificates of need and like global budgeting looking like, ideally.
Yeah. Because we have certificates of need now, but again, because it's a for-profit driven system, it's really not always based on need, and it's government run. And that's why we have to be hands-on with all of this, with all of it. We have to be hands-on. And, I would encourage some of you to, if you like, to go into, being involved with this hands-on stuff, to make sure that these facilities are put where they needed to be. The inner city and rural areas are just atrocious deserts. Women have to go 50 miles in rural communities to get to a hospital to deliver a baby. I mean, it's just ridiculous. And then, and they're closing. And the thing to remember, too, is that hospitals that close, like Hahnemann, it isn't because they weren't efficient. It isn't because they didn't do their job well. It was because of their payer mix. So if you have the same payer mix, you have a global budget, those hospitals wouldn't have to close. And so we could equify the landscape. Yes? Mm-hmm. Well, I think hospitals in general are addressing bias more than they used to, and I know I have to go through these module things, to show that I'm not biased and all. I'm not sure how helpful it is, but I like to say you need to work with attendings like me, and then you'll learn. But that's why I liked working with medical students so much, because the bias is difficult, and especially if it's been taught down for years, that it's difficult to break that cycle. And that's why it's important for you to speak up. When you see it happening with patients that you are taking care of or are on the service that you're on, you need to bring it up. I mean, I've still seen residents who think that sickle cell crisis patients are drug seeking. I still see it. So it is there, and we need to be vocal and push for it, and be loud. Be loud. Yes.
In terms of curriculum, I think students often don't realize the power they have in case in point, I'm in along with University. There was about a maybe 10% of the class that wasn't. And some of the folks wanted to serve in the certificate, but when they went to the mentality class, they went to the mentality every side and so they were like, how the hell am I supposed to know what this looks like on the one you were talking? They never want to see that place.
Mm-hmm.
You can ask the teacher, this you know, does this only apply to white people? Do only white people have cardiovascular disease? Because of all of the case studies that we see, white male, white female, without awareness. And I think that's something that we can really think for among black people, where the varieties of these people how they affect people differently than maybe this we got a little bit like.
Yeah, it is important because we often, don't see it, and that's become considered normal, is, with those slides, and who knows how old they are, and if they don't see black patients in their practice, they may not ever get any slides that show a certain lesion on black skin or darker skin. And I think we need to be careful just about biases in how we come up with a differential, is what can be wrong with this person. I had a patient who came in, a white male who came in with bone pain, and I never once thought about sickle cell crisis, but he had sickle cell anemia. And I'm thinking, how did it? Well, it's from sub-Saharan Africa, and when you look at, the colonization of that area in the country by white Europeans, you can see how white people can have sickle cell. But it prejudices, I was biased. It can't be that. Maybe he's got leukemia, that's why he's got bone pain. I mean, I am biased, and you have to catch yourself on it. So, I don't let anyone on my services ever say, 64-year-old black male or 64-year-old white female. I mean, it's unimportant. It's just like chest pain. It doesn't matter if you have diabetes, hypertension, CKD. If you look at whether their chest pain is cardiac depends on how they describe the chest pain. If they say it's here, right here, and they points and it's sore, it doesn't matter those other risk factors. This isn't cardiac pain. So you can't be biased, okay? And it takes work to do that. I think we're out of time, but was there one more question? Okay. Thank you very much, and I hope you enjoyed this.